So I'm going to try to do this sitting down from this position, from the center of the room rather than standing. Welcome to the final session where we are going to do collectively some discussion and introspection about what we've heard over the course of today. And given the fact that this was a particularly rich experience today for me, I trust it is for most of you, both today and yesterday. I think we've got a lot to take in and digest and reflect upon. So I am going to start off a little bit here in a second. I'm going to say some thank yous to give each of you a chance to reflect a little bit, get ready for what's going to need to be a pretty intense discussion if we want to get the kind of reflection that I suspect that many of you may have on the record. So first of all, some thank yous. Gillian, you have done a marvelous job with the Planning Committee in terms of preparing what's an outstanding workshop. And I'd like to thank you and the members of the Roundtable that served on the Planning Committee and the others for this outstanding program and your efforts. Thank you. I want to make sure before we quit that I thank the Institute of Medicine staff under Alina's Bachu's excellent leadership. Thank you very much. These discussions are not rich and not learning discussions without the careful preparation and skillful presentation of those that have taken the trouble to present and those that have led the panels today. I had their names here a second ago and I don't have them now, but you know who you are, the three of you. I want to thank you each for leading the panels and the presenters. Thank you so much. And then the Roundtable members, thank you for your questions, and I'm going to thank you in advance for what I know is going to be some insightful comments. Now, have we got some microphones that are active besides the ones around the table? Over here and here. I am going to try to, where appropriate, include comments from the rest of you as well, not only the Roundtable members. So if you do have something you want to say, you might take the trouble to stand up and stand at the microphone and yell if I don't see you, so that we get you into the conversation. So a couple of comments to get us started. The title of the workshop, Health and Education Working Together for Common Goals. I think we heard at least one point of view is that we ought to be working together for divergent goals, common purpose for divergent goals, and thinking about the reciprocal relationship of these two fields. Peter Orzag was just terrific in terms of pointing out that healthcare is eating the socioeconomic heart and soul of the country through its costs and so forth. My words, the summary of his elegant presentation. We've had several comments, I think eloquent comments, about silos, both in government and in the private sector, and what we need in terms of to break down those silos, work across them. We have a section that I think, Sandy, and some of your planning that you and I participated in Minneapolis, I would term under the title of Gives and Gets from the health and the education sector. So on the give side, from health care and health to education, I would take a serious look at the conditions under which healthy students can be, health can be improved of students to enhance learning, and for us to be in a position, us I mean health and healthcare, of being in a position of understanding more clearly the needs, objectives, and issues in the health, in the education sector. And then obviously we've talked a little bit about a lot about the tremendous impacts of education on health, the other sector, including the fact that increased educational attainment and some mention of increased health literacy, although we've not talked about that much. George Flores in a comment on the web has noted that we've said relatively little about curriculum content that teaches health literacy and life skills toward healthier lifestyles. Could you imagine that a case could be built for including such learning in a curricula at all levels of K-12 through education, as an example? So if you'll excuse me for giving a tad of emphasis to health literacy, obviously that's a key issue. The other get from increased education that healthcare gets or health gets is decreased prevalence of disease, decreased utilization of chronic disease, improved cost, and improved function in terms of people that I've picked out from some of the slides. Kent McGuire here on this last panel, a stunning group of slides on education in the Southwest, and I just imagine those stunning slides I've seen in terms of healthcare, a whole thing in terms of the country and those patterns and how they line up. I think thank you for doing that, and then digging into and reminding us that we really need to dig deeply into the strategies that might lead to a broad and systematic change in terms of both education and health. And then, which I've mentioned several times, Charles Bash's 7 priorities, and really pondering how, at least from my personal perspective, that might be built upon. I really like Steve Wolf's awareness, insight, and action sort of 3-part framework. And I'm going to suggest that when we do our reflections, we think about what insights, what awareness we've come to in this workshop, what insights that are particularly profound and useful for us in terms of moving forward that might inform action that we might take as a roundtable or that the country might take as a whole. And then lastly, Terry Wright's just compelling description, digging deep into the social factors of poverty in schools. So those are some of very, very quick skimming and leaving out of a lot of important things. I look again at Bob Kaplan, and I really thank him once again for that very profound analysis of and recounting of what was a terrific day yesterday at the NIH, and thank you for coordinating with this workshop. So those are some very high-level sorts of skimming comments. And now, reflections from the rest of you. What did you learn? What awareness did you get? What insights do you have? What suggestions do you have that might inform action? You want to start, Dave? I can't believe this group is so shy.
Well, you usually call me last, right? So I'd rather go first. So I don't know how these are categorized, but I have 3 things that I made notes about. First is the takeaway from yesterday that I'd like to emphasize that we just touched on briefly this morning is that the science, so there's a lot of talk here today about health behaviors and education and health behaviors and ways that we might work to remedy those. The science by and large tells us that while they're obviously important in the determinant chain, they're primarily, particularly in low performing situations, they're socially, contextually determined. And so it's just a big mistake to think that behaviors operate alone, without the contextual underpinning. And the thing that actually I learned yesterday, and which Peter Orszag knew, is that amazing, that actually that contextual gap is growing in the most recent time period. So so that's something we really have to keep track of. That's just a science piece I think we just really have to keep in mind. So second, so I'm going to try again what I didn't do very well an hour ago, but I was encouraged by one of our discussants to bring it up again. So here's what I was trying to say. You can't see, I wish I could do a slide. There's 2 circles here with a Venn diagram. So the left-hand one I just labeled educational policy priorities. That's probably a lame characterization, but sort of what we're talking about here that needs enhancement for co-benefits. And on the other hand are health and public health capabilities. And so there's an intersection. They don't totally overlap, but there's an intersection where health, educational policy priorities intersect with health and public health capabilities. And in that, and thanks again to Kent, I think we can think, he challenged us to actually think of it in two ways. One are those that we can approach from a joint policy advocacy perspective, you know, working, and another one where we can actually do joint programs together. We're at a sort of a different level. And he actually said, well, there's work to do to sort of fill in those boxes. So I offer that again. And then finally, I look at a lot of these maps, but actually the map of the education investment map of Kent's, which, you know, has to be true, but I never kind of seen it before. And it's just such a huge challenge. And then I've been wondering about, you know, Orzag was talking about how Medicaid expenditures sort of cut into education and social expenditures, but that probably is not the case in the South. But how we really look carefully at those numbers and what produced them historically and what we may possibly do to change them, I think is huge.
Thank you. Bob? And then, you know, let's use the card sort of mechanism that we have for identifying potential to speak. And Stephanie, you're going to be after Bob.
Thank you.
Sure, a couple observations. First of all, back to where we were yesterday and part of today, I do think that the effect of education on health outcome is just so remarkably large that we have to approach it, or we have to address it. But I'm still left puzzled with what exactly we do. And I was impressed with Charles Bosch's comment that, you know, I think it is time to develop some sort of strategic plan, and to really sit back and say, you know, what are the exact steps that are necessary to make some progress. And I just want to throw out one question. You know, the last thing we want to do is endorse paternalism, and we've heard a lot today about engagement. On the other hand, you know, when I talk to public health directors, what I hear from them often is that they want more paternalism. I'll give you a couple examples. They say, we want the schools to require measles vaccinations as a criterion for entering school. Or they tell us, we want someone to deal with these people in our communities who are opposing fluoridation in the water. And I think that we have to put a lot of thought into exactly how we deal with community input when community input actually may be in conflict with the goal of promoting health.
Thank you. Stephanie Zaza.
Thank you. I'm Stephanie Zaza. I'm the Director of the Division of Adolescent and School Health at CDC. Holly mentioned earlier that this is now a split program. Her program focuses on chronic disease elements. The Division of Adolescent and School Health recently moved in the past couple of years to focus on sexual health, and predominantly in adolescents, obviously. We also continue to operate all of the elements of school-based surveillance. So YRBS, which we saw some data from, the SHIPS program that somebody referenced earlier, and the school health profiles. So we have lots of data that are publicly available, and I'll just make a pitch that next week on the 12th of June, the 2013 data will be released, and those are released simultaneously in the MMWR and online, so you can dig into those data at your will. They're publicly available. I wanted to make a couple of observations about evidence and what's required to make decisions. I was pleased to learn that recently the Task Force on Community Preventive Services, which George was a member of for a very long time, recently made recommendations for a portfolio of educational interventions. So they now have, many years ago, they actually had recommended early childhood programs. And then recently this summer, they've released 3 interventions that they recommend. One is full day kindergarten for children in poverty. The other is out of school academic enrichment programs. And the third is high school completion programs. The real innovation in this work is not that they did these reviews, which is pretty spectacular, but that they actually allowed educational attainment outcomes to be their measures of success and not requiring specific health outcomes as measures. I think we saw some compelling evidence today that educational attainment in and of itself is so strongly correlated with long-term health outcomes that for a health group like the Task Force on Community Preventive Services to take that step, that was the thing that held them back from doing those reviews for so long, was the concern that there would never be health outcomes to measure, and they were probably right. So I do think that there's this sort of tension for health groups to feel like they're maybe getting in someone else's space if they make recommendations for high school completion programs. I was compelled by the evidence on that step down, that drop off at grade 12. And so if there's one thing that I'm taking away from this, it's that high school completion programs may be one of the most important things that we can offer as health people to sort of change the trajectory if there's sort of one piece of that to take forward. And then the only other piece that I'd mention is it's very easy for us, again, in health to sort of retreat to the health delivery, the health infrastructure sorts of pieces of that, and we're no exception. As part of the work we're doing in sexual health programmatically with the education agencies that we fund is access to sexual health services for adolescents. But this holds for all kinds of health services. What we don't know about the infrastructure that is available to students in this country is a lot. So just beginning to do some of that work in terms of how, where are there schools with absolutely no delivery of health services, no school nurse, no access to health services at all? Where are there school nurse programs? Where are there school-based health centers? And what can be done and what should be expected in those different layers of health infrastructure at school, those different kinds of health infrastructure? One of our first forays into this world was we released a study on May 19th in JAMA Pediatrics, an important first time ever cost-benefit analysis of school nursing. It's an evaluation of the school nursing program in Massachusetts that we did with the National Association of School Nurses, and showed a very clear beneficial ratio to having school nurses as opposed to not having them on the part of the schools, the parents, and the community overall. So I think that there's a lot of work to do in this arena, and figuring out where we can all contribute is really important. So I encourage you to take a look at the community guide reviews. Like Steve, I don't think we just hand over a systematic review and say, do this. I think the real work is in how do you take that and filter it and boil it down and create the products that the schools can use then to take that information and use it. So thank you.
Great, thank you very much. Sandy Magden, then Jose, and then Sarah,
So I have
and then Debbie.
2 points. One is from Peter Orzog, and which he talked about the rising healthcare costs and essentially are going to rob the social determinants of health. And I talked to him afterwards and I said, I'm really worried that this movement from fee-for-service to a different kind of payment model that is good for population health, it's good for value, it's good for taking waste out, is stalling. And he said, yes, he's worried about that too. And he told us that right now we don't have a glide path for people to see how to get from where we are now to this new world. And so I want us to think as Institute of Medicine and the Roundtable on Population Health, what role we can play in helping create, support, build an infrastructure to help with that glide path, to help with figuring out how to get from that kind of payment world and medical infrastructure that we live in now to a different kind. And remember, he said the second thing. The first one was the glide path. The second was this population health revolution, he said. And I think to have the healthcare system see themselves as part of being responsible for that as we make this change that more organizations like Kaiser have done long term, but you still got a lot of this medical infrastructure that needs to be changed also. So that's the first thing. The second thing was really in what Kent was talking about with the language we use and the communication. You know, as chair of the communication group, that really hit me again about our communication and how health focused we are and how maybe we should be leading with education and this whole opportunity for finding the commonalities in that. And I loved what you said, Kent, about developing principles, and we actually have that in our roundtable for communication that during 2015, we developed a set of communication principles by which to enhance population health messages to key audiences. Maybe we ought to be doing that together. I mean, I love what you said about just, how much time that took getting people around the table, that we shouldn't be thinking about developing these by ourselves, but maybe I should interview you if you'd be willing about what have you learned already about language and communication and principles.
Jose Montero.
Thank you. Sunny said a few of the things that I wanted to highlight. It's been a quite amazing couple of days. We all were kind of aware of this interaction between education and health outcomes happening. We look at the BRFFS data in our own states, and it is clear to us that that is what is happening. The details of how it happens, I don't think that we have yet mastered. And there are clear areas for a research agenda to help us identify better those areas where we can have more impact and move things forward. At the same time, we cannot wait forever to have all of the data and all of the research that we can collect from an academic approach, but try to take all of these natural experiments that are occurring and use them to advance this particular agenda. It always worries me that we look at health as our sector and education is another sector. And when I go around and talk about integration of public health and healthcare or state health improvement plans, I always end in somebody else's field. And I really cannot care less, because doing advocacy for what it is right beyond what structure or sector we come from is the right thing to do. If we are at a place where we can use our bully pulpit for any pieces of the spectrum that will help us lift health outcomes, we should do that. And there is evidence for that. We look at what the group that Jeff is the chair, Health Promotion and Disease Prevention National Task Force. I made up the name, but it's close to that. Already published the evidence, and most of those things are not necessarily in the clinical sector. Actually, seldom are, but it goes beyond that. And that is where we need to bring this a little more and develop it more. I look at ACOs as a wonderful opportunity for us to look at this new type of workforce that we need. Based on these levels of education, how do we mix those community health outreach workers that we have in the public health sector with the health coaches that the new ACO models are developing or advocating for, and marry that with what the other sectors have, the school clinics have, as was presented earlier today, and use those to advance those health outcomes that we are looking for. So a lot still to process. I see specific things for us as public health directors and government enterprise to do with this information, to go back to our own states or at the national, federal, local level to talk to our counterparts with clear data, but as a roundtable where the representation of wide sector and foundations and not-profit, we need to help identify the key points for advocacy to move this and allows us to jump into this somebody else's sector to do the proper advocacy for it.
Thank you very much, Jose. I totally resonate with your general awareness and then learning a lot of the detail today. I was in the same boat as well. Sarah Lind.
So I serve as the Chief Public Health Officer at HRSA, and obviously also I'm a commission corps in the Public Health Service. I wanted to just build a little bit on what Bob said and now what Jose just introduced, and that is I had pulled up the National Prevention Strategy during one of the talks, and while we talk about, education as an important component and important sector in that strategy, there were not a lot of concrete actions there that would link health and education. And so that may be an activity or an action-oriented, focus if we're building a strategic plan to build off of that, because so many of the overarching themes that we talk about are addressed in the National Prevention Strategy. But if we're looking to really develop some concrete actions, re-looking at that strategy and the priorities with a focus on all of the things we've learned today may be helpful.
Thank you. Mary Pittman.
From an awareness, over the past 2 days, we had a lot of strong evidence for the interdependence of biology, health, and education. And yesterday, a lot more was focused on the biology part of it, with the ACEs evidence that was shared, and also the real brain development and the carryover throughout the life course with biological evidence, which I knew some of that, but it raised my awareness in thinking that this is something that we're going to have to be talking about, I think, in an even more sophisticated way than we have been, because I think some of the insights from yesterday really talked about why it's important for us to start our interventions very early in the life course, but to see it carried through the entire life course. So my insight was both sectors are really trying to take a look at equity, and that equity is one of those driving factors that we really have to bring up in every conversation. And particularly it's salient when you're looking at young children and the disequilibrium that we're bringing. 50% of the kids in this country are in poverty, and the need for us to lift that up in our actions, which I would say have to cover all areas. We're going to have to raise awareness about these issues. We're going to have to talk about the complexity of these issues and identify ways to highlight the contextual gaps and to target our communications at multiple levels so that we're stimulating the political will, because we keep going back to, we can't, there's always going to be a gap in the resources. I think a lot of it is connecting the dots. We've heard a lot, connecting the dots, and then creating an action plan that will address the gaps, create more political will for the interventions that'll allow us to link up with the other sectors who have a common frame that they're working from, and also to highlight some of these interventions are not high-cost interventions, but they're interventions that have been shown to work, and I think we need to be integrating that into the framework and the map.
Thank you. Debbie Chang? You need to use your microphone or the rest of the world won't know you're going to say something.
I had 3 thoughts. The first is that it's been a great 2 days, and yesterday was just a tremendous amount of data on the relationship between education and the impact on health, and some on the biology, I thought. I guess it made me think about moving to action and interventions. And I think when you look at interventions, the interventions often are health working in the school sector. And so even if I looked at our early care and education work, we're bringing health in a way to early care and education. And it made me think that one thing that would be really important in terms of an action is when we have these interventions, or whatever we're calling them, programs, that we ought to come up with a small set of metrics that are both health and education. So I liked I think she's gone now, but Lori had a set of metrics that were, increased physical activity, but also increased educational attainment. And it made me think that in terms of an action, even for myself, that I want to go back and explore is we should be looking at the impact of our obesity programs on a child's readiness to enter into kindergarten. And so I think if we want to really look at the co-benefits, we ought to have a small set of metrics that we all are using. To the point that Lowell raised, his last point was about accountability. And this builds on what Kent was saying, a small set of metrics, but both education and health. And then another different thought I had was that, again, this question of where does a roundtable add value? And to really think about where is it that we add value. And I think clearly in terms of national, federal, breaking down silos, helping to facilitate conversations, working on collective impact, that at the national, federal level, that seems like an area. And building on Sandy's point, focusing on the imperative to develop payment reforms that include population health, maybe one of those. I guess, and then the third comment I would have is, just trying to figure out how best to say this, I think there's a lot we could be doing, and one of the reasons we got together was action. So the thought of another strategic plan, it doesn't excite me much. And I want to, maybe it's needed, but maybe it's needed in a very, if we're going to do something like that, let's be really targeted about what the strategic plan is looking at and the purpose, and spend some time really talking about it. And then I would add finally that I think that Jeff and I forget what the title is, Jeff, but the prevention strategy, there was a group that looked at and still is looking at the nexus between education and health. And in fact, I was on a work group that was making recommendations to an advisory group that was then going to make recommendations. And I know that Jeff is still doing work. It sounds like anyways, but there's still work that's happening in that area. So to your point, Sarah, I think we need to share that information. So.
Thank you, Debbie. Peggy Ornery. You also use your, yeah.
I wanted to support Mary's comments about equity, which I think is definitely spot on, and a good example of that is the conversation that we've had today about education. And I think everybody in the room will agree that there's a strong relationship between good health and educational attainment. But it also has a relationship to income. So just because a person is educated, if there's not equity in the income that person can earn and the job that person can have, that's a problem. Housing, same thing. There has to be equity that rolls off of all of these determinants that are so related. And if we're siloed and only looking at one, I don't think that we can achieve as a nation what it is that I think we want to do, and that is population health improvement. I just don't think that we can look at this in a siloed fashion and think that education alone is going to get us there. I know a lot of very educated, underemployed people. Also, I think that we should listen very clearly to what, and I don't remember what his exact response was, when David Orzog, when he was asked the question about our big goal for life expectancy. He was very cautious about having such a goal with the resources attached to that. And I think a lot of times that we have these big, lofty goals and we don't put them through the political magnifying glass, and maybe sometimes we shouldn't. Maybe we should ignore rules like political will some of the time. But I think a lot of times we wind up with a portfolio of recommendations that don't go anywhere either because they're just not realistic.
Yeah, that's some very interesting comments, and I just would say that one of my other observations that's prompted by your comments is that I think in a sense we've had an opportunity to go to school on the multi-sector sort of approach by digging into health and education in this workshop. And I don't know that by digging into this topic so deeply in the last 2 days, we would in any way walk away from our stakeholder sort of assumption that that's going to be necessary to improve population health in total in the country. But it certainly has been a provocative day or two. And I don't know, Peter Arzog is such a terrific guy, tremendous insight. I would hesitate to disagree with him, but I think his point of view is an opinion on the larger goal. So Martha? Martha?
So many great comments here. I sort of apologize for being so sort of concrete and narrow. And I think the irony here is I'm going to talk about the medical care system, which is something that I almost never talk about. But I was just very impressed by Flavio Cumba's discussion of sort of how many words one learns and hears early along. And so I was thinking about, I haven't kept up with the anticipatory guidance piece of the U.S. Preventive Services Task Force for Pediatric Screening, but it just seemed to me very useful to have the task force sort of look at that evidence base, if they haven't, to make some sort of recommendations. And my point being, you know, it seems like at worst, it won't do enough, but at best it will do a lot. And what it also does is it serves to educate the medical care system that there are things that we know about health that don't have to do with medical care per se, but actually the sort of plasticity of the brain and what we want a child to know. So I just would want to flag that as something that we might concretely do to the task force. The other thing—
Martha, before you leave that, just so the operative guide is Bright Futures for Kids under the ACA, and I was at a talk where it was said that Bright Futures is actually adding a section on social determinants.
Thank you. And then just going back to this exciting news that the community guide is now talking about educational achievement as a sort of an outcome. I think that's great. I'm wondering, as we think about metrics, about sort of somewhere having a simple tool that people can sort of look at educational interventions to see how they move forward in getting people to graduate, and that there's just a way that one can just pop that into a model and people can then translate into increased life expectancy based on the data that we have. I think that might be a good advocacy sort of thing for people to have in their hip pockets.
Along the way, we've had comments on the web that we've unfortunately not been able to reflect in real time over the course of the day. But I thought at this point, just before we close, I might read a couple of these. Some of them are questions, and they'll have to be rhetorical at this point. So in addition to the one from George Flores that I read a few minutes ago on health literacy, George also offered this comment: what remedies exist for poor performance of educational systems to prepare sufficient numbers of African American and Hispanic children to become qualified to apply for training as health professionals? I think that's an excellent question. And then we have a comment from, I believe, from Anna Armstrong in Omaha, Nebraska. And she writes, here in Omaha, we are addressing oral health through various school-based initiatives within schools with high rates of poverty. If you could spend 1 hour going out into the field with us, you would be shocked to see the state of oral health and the impact that alleviating dental pain can have on a child's ability to concentrate and focus. While educators are often concerned with vision and hearing, oral health is equally as important, as children often adapt to the increasing levels of pain that come with oral decay, which is the leading cause of chronic disease among children. From a holistic perspective, how can we improve the status quo to incorporate oral health as part of comprehensive school health? So a question from her. If there anybody in the room from the public or others who wants to step to a microphone and make an additional comment, I would take that right now. Seeing no one, Pamela Russo.
So I think yesterday and today was a very interesting combination. And I think I would want to reiterate Mary's point about the life course. I mean, there are so many intervention points that are critical to both improving educational attainment and health. And then, but I just, and we heard about lots of points of light, some exciting programs, some exciting interventions. I was sort of surprised we didn't talk about Head Start, because my sense is that's one of the broadest reaching ones out there. But to Ken's statement, it's not a system either. I mean, it's a different animal in different places. So all these great points of light, these great interventions at different points along the life course. But those slides of Ken's about the swath across the South, I mean, 50% of kids growing up in poverty, it sort of boggles the mind. And in other words, social determinants tend to run in packs, right? I mean, poor housing, poverty, poor schools, violence. I mean, they run in packs, right? And so to make a difference on one is not to fix the rest, right? Mm-hmm. And the one that you left off, Kent, was that also in the South, the highest rates of infant mortality and the highest disparities in infant mortality. So in other words, even from the very start, but you just get this sense that we're allowing all these brains, because of all the new sort of understanding on neurocognition, to be damaged. We're creating an epidemic of damaged brains, and that are going to. So we have to find the interventions. I'm not on a very positive note here. I'm still stuck by that map.
Well, thank you, Pamela. And I want to thank, I guess I've said my thank yous and made sure that, David, you want to make a final comment? And of course, I'm going to say my thank yous and say one of them is to my co-chair, David Kindig, and he's going to make a comment. Go ahead, David.
Just only stimulated by Mary's bringing up biology and what Pam just said. So attention for me is when we talk about education, so often we think about schools, and there certainly are different points of intervention, but we had a little discussion group yesterday after lunch about the first 1,000 days, and where are the sensitive periods, and there's a lot of evidence that really early is a extremely sensitive period. So I think we have to pay attention to a lot of the earlier things than in the school situation, although we need to deal with that as well. So that's all.
So once again, I'm going to thank you, Gillian Barclay, once again for just a terrific leading the planning committee, putting together this workshop, and the IOM staff. And I think if those members of the roundtable want to know where our business working dinner is at, please see Alina after the meeting. And unless there's anything else I should say, Alina? Okay.
The closed session begins at 8:30 here tomorrow.
And tomorrow morning in this building, room 101 probably, we are going to have our closed session discussion. So we stand adjourned. Thank you so much.